Prof. Yeah.
Right. So during the next few 45 minutes or so, what I try to do is to give you a basic understanding on how best to manage anemia in children in general practice. So I was specifically told not to repeat the theory aspects of this, but to make sure that the talk is relevant for the general practice. I'm a pediatrician. I work as a professor of pediatrics at Ragama, and I have sort of a keen interest on anemia and hemoglobinopathies in children. Anemia in children is one of the most common global diseases, as you know. At any age, anemia is a very common disease. It's estimated about 1/4 to 1/3 of world population are anemic. But the major burden, as you can see in this map, is in the sub-Saharan Africa. However, South Asia and Southeast Asia are not far behind. So we are in a high-risk zone for anemia, not only in children, but at any age group. Specifically, the map shows the prevalence of anemia for children aged between 6 months to 5 years, and you can see again, sub-Saharan Africa and South Asia are the high prevalent areas for anemia in children. The highest prevalence among children is found in the preschool age group, which is 6 months to 5 years. So 6 months to 5 years, the anemia is very, very common. In Sri Lanka, the data shows the prevalence of anemia in preschool children in Sri Lanka is approximately 15 to 20%. So that means 1 in 5 of our kids are anemic. Is quite comparable to other developing countries. So what I would try to do is to bring up few case scenarios and discuss around, because anemia is a very broad topic, but the common diseases encountered in general practice are quite few. The first case scenario is an 11-month-old girl who has been treated for a viral illness. So on the 3rd day of illness, a general practitioner has decided to do a full blood count. Otherwise, everything is showing a viral fever. And the full blood count, you look at the platelets, which are normal, and the hemoglobin is 10.1. So incidentally, you have found a hemoglobin of 10.1. The question is this normal or is this abnormal?
So this may be normal. We have to recheck the hemoglobin level after 2 weeks time.
Yeah. So you check it after 2 weeks, it's again the same. 10.1.
It's abnormal. Yeah, it's abnormal.
Then it is abnormal.
When do you consider it as abnormal? 10.8? 11? 11.5? Right. So the answer to that is actually not known. It's very, very controversial, the definition for anemia in children. But at present, we go by the WHO guidelines, which have recently changed. And according to the WHO cutoff values, hemoglobin less than 10.5 in a child who's between 6 months to 2 years is considered as anemia. The cutoff for anemia in children between 2 to 5 years is 11, and 5 to 12 years is 11.5. So technically, this child is having anemia with a hemoglobin of 10.1. What happens below 6 months? What is the scenario? Making a single cutoff below 6 months is hard. Generally, you will not encounter children below 6 months with full blood counts, because it's not so common for you to prick a 6-month-old or less than 6-month-old child and because the viral illnesses are not so common in that age group. But if you happen to see them, and if you happen to see them as pale, you might consider doing a full blood count. But in a child who's less than 6 months, the hemoglobin can vary significantly, the normal hemoglobin. You see the hemoglobin cutoff, sort of a -2 SD hemoglobin in the orange bar, which shows the hemoglobin, highest hemoglobin at any age group is seen at day 1 of life. So you will have a highest hemoglobin in your life on first day of life. So at birth, the neonates will have a normal hemoglobin between 15 to 24. So if it is less than 15, that is anemia, right? So 15 to 24 is the normal. But soon after birth, the hemoglobin drastically drops to a lower level, and the lowest value is found around 2 months of age. And even a hemoglobin of about 9.5, provided other things are normal, provided the clinical examination is normal, can be normal, which is known as physiological anemia of infancy. After 2 months, the hemoglobin gradually starts picking up, and by 6 months of age, the normal hemoglobin should be about 10.5 grams per deciliter. So what's this physiological anemia of infancy, which is seen during the first 6 months of life? As I have told you, the normal hemoglobin at birth is 15 to 24. And over the next 8 weeks, it drops drastically to a very low levels, can even be 9 or 9.5 grams per deciliter. Why does this happen? So the fetus is in a hypoxic environment where the saturations have been about 50%, but soon after birth, with the first breath, the oxygen saturation drastically rises to 95%. So the need for hemoglobin or red blood cell drastically decreases. So there will be excess oxygen delivery to the tissues, and there will be plenty of oxygen. This invariably decreases erythropoietin production and suppresses erythropoiesis. So all these factors will support, help for this physiological anemia, but at the oxygen carrying sort of a oxygen delivery, therefore the erythropoietin production commences, and the full blood count and a hemoglobin of 9.5 in a 2-month-old baby. Don't be alarmed. Look at the other cell lines. Look at the red cell indices, which we are going to describe in the next few slides. And if they all are normal, just disregard. You even don't have to repeat it. It will be a physiological thing. But if you want to make sure, just repeat it around 6 months to make sure it has gone up to 10.5. So that's one take-home message. So coming back to this child, who is an 11-month-old girl with a viral illness. Now we have the hemoglobin of 10.1. The first thing when you see a child with anemia after doing a full examination is to look at the red cell indices, which are invariably given in the full blood count report. So what does this show? MCV 67, MCH 23, MCHC 29. Any thoughts on this?
Microcytic anemia.
Yes. So again, the definition of microcytosis is not very clear-cut in children. In adults, it's about less than 8 is considered microcytosis. Some will consider it as 78. But generally in children, the red cells are smaller. So up to about 70 can be normal even. So if it is less than 70 femtoliters, it's definitely microcytic anemia. So you can definitely narrow down your differential diagnosis for anemia based on the full blood count itself. There is no need for a blood picture. With this full blood count, you can diagnose there is microcytic anemia, and in fact, it's microcytic hypochromic because the MCH and MCHC are also low. So there's microcytic anemia. This differentiation is extremely useful, extremely valuable in further management. We know in our undergraduate days, we have learned the anemia can be divided into 3 groups: microcytic anemia, normocytic anemia, and macrocytic anemia. So the normal MCV cutoff is generally, so you don't have to memorize this, but I would consider 70 as a reasonable cutoff for children. If it is less than 70, that is definitely microcytic anemia. So the commonest form of anemia you will find in general practice in children is microcytic anemia. 90% of the time it will be microcytic anemia. If you encounter anything other than microcytic anemia, if it is macrocytic anemia, I don't think that will be a good sort of a reasonable thing for you to manage that in the general practice setting. So if it is macrocytic anemia, the differential diagnosis includes megaloblastic anemia, folate deficiency, B12 deficiency, or rare metabolic diseases, hypothyroidism. So it can even be diamond black fern anemia, which is a pure red cell aplasia. So probably you need to refer. Normocytic anemia is generally due to hemolytic. If there is a significant anemia, that is a most likely hemolytic process is going on. So a blood picture is indicated. And apart from that, probably need to refer. But the commonest form is microcytic anemia in children. It's about 90% will have microcytic anemia, which can easily be managed in the general practice settings if you follow this sort of the guide that I'm going to present in the next few slides. So our child has low MCV and microcytic anemia. So now what? So then we need to know the differential diagnosis for microcytic anemia in children. So what are they?
Hemoglobinopathies like thalassemia.
Yes, number one, thalassemia or hemoglobinopathies.
Yeah.
Number two,
Iron deficiency anemia.
Sideroblastic anemia.
very good, exactly. So the commonest cause for microcytic anemia is iron deficiency anemia, and the second commonest cause is in this part of the world is hemoglobinopathies. So those are the two most common entities that you will encounter. The other ones are very, very rare. Microcytic anemia is due to a defective production of hemoglobin. So the things that are needed for hemoglobin are less there. So lack of iron leads to iron deficiency anemia. Lack of globin leads to thalassemia. So the thalassemia major will generally present with hepatomegaly, splenomegaly, and other clinical features. When the clinical examination is normal and a child is found incidentally found to have anemia, it's either iron deficiency anemia or thalassemia trait if it is microcytic anemia. The rare ones are anemia of inflammation or anemia of chronic disease, sideroblastic anemia, and lead poisoning, which are extremely rare. So the two common causes for microcytic anemia are iron deficiency anemia and thalassemia trait, which needs to be differentiated, and it can be done in the general practitioner setting. Your full blood count will also help to roughly show, make the differentiation, but I wouldn't recommend going by purely the full blood count. But for your knowledge, in iron deficiency anemia, the red cell distribution width is increased, red blood cell count is reduced, and MCHC is reduced, whereas in thalassemia trait, your red blood cell distribution width is normal. Red cell count is generally normal, and MCHC is also normal. So, but this differentiation is not very, very robust. So you don't generally go by this. So, however, the most likely diagnosis is iron deficiency anemia. But before embarking on treatment, we need to make sure that this is iron deficiency and confirm the diagnosis, which we will discuss. So this child is most likely to have iron deficiency anemia. However, there is a possibility of thalassemia trait as well. So a few slides about iron deficiency. We know iron deficiency can be there without iron deficiency anemia, without anemia. That is the initial stages. They will have low iron stores and normal hemoglobin. But when the iron deficiency is progressing, it will lead to iron deficiency anemia with low iron stores and low hemoglobin. The risk factors for iron deficiency, in less than 6 months, the iron deficiency anemia is extremely rare. So I don't think you have to worry too much. So don't worry about those. The iron deficiency risk increases, or the prevalence increases after 6 months. Late infancy and first sort of 2 years are the high risk groups. The most commonly it is due to poor weaning with iron-less food, insufficient dietary iron intake. However, things like occult blood loss due to protein, cow's milk protein colitis, Meckel's diverticulum, inflammatory bowel disease, or rarely hookworm infestations can also lead to iron deficiency in children. But the most common cause for iron deficiency anemia in children is dietary iron deficiency. Clinical features of iron deficiency are extremely rare. So there is generally an asymptomatic condition. However, when it is severe, you may encounter children having pica, eating non-nutrient substances, maybe rice, maybe soil, maybe stones, right? Whatever they get, you will eat. This is known as pica. The other clinical features when the anemia is severe can be irritability, anorexia, lethargy, tachycardia, and you might hear some ejection systolic flow murmurs even when there is iron deficiency anemia. Those are basically features of anemia, not iron deficiency. The features of iron deficiency per se are pica, and phagocytia is the ingestion of ice. So once you suspect, so now the full blood count shows most likely this is iron deficiency. How would you confirm the diagnosis? Even today, there's no gold standard test to diagnose iron deficiency. There are so many tests, but every test have its own deficiencies and limitations. Most widely used test is serum ferritin, which can be done in any laboratory. The cost is not huge, so it's about maximum 2,000, 3,000. So it's a reasonable test to do even in the general practice. So it's have a high sensitivity, but the specificity is low. So your serum ferritin less than 15 nanograms per milliliter, you definitely can diagnose as iron deficiency. But if the serum ferritin is 15 to 30%, sort of it can be borderline. However, you need to know that the serum ferritin can be falsely elevated even in children who have iron deficiency if there is an inflammation. So if someone has chronic infection or maybe even dengue, the serum ferritin might go up to even to thousands because serum ferritin is an acute phase reactance, although the child is having iron deficiency. So the take-home message is if the ferritin is less than 15%, that is definitely iron deficiency anemia, no question. But if it is more than 15%, you may not be very sure because it may be due to inflammation. So you have to repeat it when the acute inflammation is settled. So the other things that can be done now, which are not very widely available, are serum iron, total iron binding capacity, and transferrin saturation, which is known as iron profile. I generally don't do iron profile. I don't recommend doing iron profile. Even if you have limitations with ferritin, what you can do is just the transferrin saturation. Only transferrin saturation can give all the information that you need. Normal transferrin saturation is about 30%. If it is less than 16%, that invariably is diagnostic of iron deficiency anemia. So the two tests you may consider serum ferritin and transferrin saturation. You don't have to do both. One is good enough and they are not that costly. So consider doing one of these tests before you start treating iron deficiency anemia to make sure this child has iron deficiency anemia. If you are unable to do the test, right? If the parents can't afford, if sort of that they are not widely available, another option is to give an empirical trial of iron. So which is also recommended, especially in children less than 2 years. If the child is 6 months to 2 years, if the child has microcytic anemia, it's recommended if you can't do a ferritin or transferrin saturation, you can give the appropriate dose of iron, but always you have to confirm it by showing a response to iron treatment. So if there is a good response to iron treatment, which is defined as a hemoglobin rise more than 1 gram per deciliter after 4 weeks of treatment. You start iron treatment, after 4 weeks, you do a full blood count, the HB has gone up by 1 gram. So that again can confirm that it was iron deficiency anemia, which is known as empirical trial of iron. How do you treat iron deficiency? Obviously with iron syrups, but I'm sure you know, the iron is something that you do not prescribe in generics because different, at least in children, because different iron preparations have different amounts of iron. The dose is defined by the amount of elemental iron. So the treatment dose of iron deficiency anemia or iron therapy is 3 to 6 milligrams of elemental iron per day, maximum 150 milligrams. So get used to the practice of using 1 or 2 syrups and maybe drops, and make sure you know exactly the amount of iron in those. Normal multivitamin syrups which contains iron will not be sufficient to treat iron deficiency. You need to use a iron containing syrup, only iron. So generally the iron drops will have 50 milligrams of elemental iron in 1 ml. Normal iron syrups will have 50 milligrams in 5 ml. But double check by going through the drug information leaflet. Iron tablets, normal ferrous sulfate tablet has about 60 milligrams of elemental iron, but there are some commercial capsules which have 100 milligrams of elemental iron per tablet. So get used to 1 or 2 preparations and exactly know how much of elemental iron each contains. So you can use them sort of properly. The dose is 3 to 6 milligrams of elemental iron per day. Earlier, the recommendation was to give 2 to 3 divided doses, but now the recommendation is to give as a single daily dose. And people are really trying whether giving every other day is going to be the most useful thing. But the current recommendation is to give a single daily dose before meals. So you don't give it after meals, 30 minutes before or 2 hours after if you really want to give it after meals to improve the absorption. Iron is well tolerated by children, minimal side effects, but there can be unpleasant taste, gastrointestinal complaints. So the treating iron deficiency anemia once diagnosed is easy. So what is the place for other supplementary things? So we have seen very often people prescribing iron, vitamin C, folic acid and everything. To be honest, to treat iron deficiency anemia, none is useful. So there's no point giving vitamin C along with iron. There's no point giving folic acid unless the child is folate deficient. Vitamin C will invariably improve the iron absorption, but it will be sort of it's not recommended. Giving the appropriate dose of iron is good enough. There's no need for supplementing it vitamin C. Do you need to give antiworm treatment? Not at all, because only sort of a common worm infection that causes iron deficiency is hookworm infection or Necato-enkylostoma, which is extremely rare in this country nowadays. The prevalence of hookworm infection is less than 1% even in high prevalent estate sector. So you don't blanketly give antihelminthic treatment unless there is some other indication. So no point giving antiworm treatment when you are treating iron deficiency anemia. Oral iron is very good. It has a good bioavailability and the response to iron treatment is very high. So there's no need of parenteral iron. So inward management is not necessary. So this can be managed in the general practice. Only indication for parenteral iron if there is a malabsorption or rare diseases like iron refractory iron deficiency anemia, which is beyond this lecture. Do we need to transfuse blood? Generally not. Your iron deficiency anemia can be very severe sometimes. The hemoglobin, we have seen children with hemoglobin of 4 due to iron deficiency anemia and purely iron deficiency anemia. Even in those children, we tend not to use blood. Why? Because the treatment response to oral iron is so rapid. Within 1 to 2 weeks, the hemoglobin rises rapidly. So the blood transfusions are generally not indicated even if the hemoglobin is very, very low, because this has been a chronic process and the body is well adapted to low hemoglobin. However, if the child has impending cardiac failure with features of tachycardia due to anemia, then there is an indication for cautious blood transfusion. The other aspect in the management of iron deficiency anemia is dietary modification. You have to advise on taking iron, food rich in iron, right? So the meat, fish, egg yolk, green vegetables, pulses, those are the iron-rich food. By taking vitamin C containing food, maybe citrus food along with iron containing food can always increase the iron absorption, which can be recommended. And avoiding consumption of tea along with meals also is supportive of increasing iron absorption from that meal. So those advice can be given in the general practice to anyone who has iron deficiency anemia. Just giving iron is not good enough. You have to monitor the response to treatment. How do you monitor? Ideally, if you are in a hospital, if you really want to monitor the urgent response, the best is to do a reticulocyte count, which will go up within 2 to 4 days. In practice, we don't do that. In practice, what is recommended is to repeat the hemoglobin after 1 month. So if we have shown 1 to 2 grams per deciliter rise of hemoglobin, that confirms iron deficiency, and that confirms that the iron deficiency is responsive to treatment. There's no need of repeating ferritin or iron studies. Only thing to repeat is hemoglobin. So you can repeat the hemoglobin monthly until the hemoglobin is normalized. In a child between 6 months to 2 years, 10.5, 2 to 5 years, 11, and more than 5 years, 11.5. Once it is normalized, you continue iron treatment for another 3 months to make sure that the iron stores are replaced, and then stop iron treatment. However, the dietary advice should be reinforced and dietary management should continue. So that's the management of iron deficiency anemia. Very easy, very straightforward, and can be managed precisely in the general practice settings if you have access to a few investigations. You have seen we have not done even a blood picture. There's no necessity for blood picture because the blood picture will not be able to differentiate from thalassemia trait and iron deficiency anemia. If you do the ferritin, that is good enough to confirm iron deficiency anemia. Any questions so far?
Prof. Sachit, I'm Dr. Praneeth.
Yeah.
It's regarding tea. Is there any indication to stop coffee as well?
Yeah, generally what we consume is tea, but tea and coffee both impairs the iron absorption. So you recommend stopping both.
Thank you.
Right, we'll move to the second case scenario. Let's say sort of a 3-year-old boy, again a viral illness. You do a full examination, which is unremarkable. Hemoglobin this time is 9. So we know it's obviously anemia. And you look at the red cell indices. As soon as you see the hemoglobin, you have to look at the other cell lines, white cell count and platelets, to make sure they are normal. If they are not normal, then we are dealing with something else, maybe a bicytopenia, pancytopenia, something sinister. So if the platelet count is also low, if that cannot be explained by the viral illness, if like dengue, then you have to immediately refer. But I'm talking about isolated anemia, and the MCV is 57. So you thought this is most likely iron deficiency anemia. You have facilities to do the serum ferritin. You have done a ferritin, and you have excluded acute infection, inflammation. When the child was well, you did the ferritin, and the ferritin has come as 80. So what can this be?
Thalassemia trait?
Yeah, most likely this is the other differential diagnosis. Very likely this is thalassemia trait. We know there's thalassemia has 2 forms, alpha and beta thalassemia trait. So of which sort of a common thing that we encounter in clinical practice is beta thalassemia trait. So however, it is probably going to be thalassemia trait. But thalassemia trait needs to be confirmed. How do you do that?
HbA1c?
Yes, doing blood picture here is again not useful. It will always say microcytic hypochromic anemia, iron deficiency plus or minus thalassemia trait. So I have given up the practice of doing blood pictures when I encounter microcytic anemia, because microcytosis we can detect from the full blood count itself. However, if you detect macrocytic anemia or normocytic anemia, blood picture is critical and crucial, very, very important. In microcytic anemia, blood picture is less useful and it's just a waste of resources. So now we know it's most likely thalassemia trait. We need to do an investigation to confirm, which is the hemoglobin HPLC. Newer machines use what the technique known as capillary electrophoresis. So what both more or less the same, HPLC or capillary electrophoresis, which will give you the proportion of hemoglobin in your body. What proportion is hemoglobin A, what proportion is hemoglobin A2, what proportion is hemoglobin F, likewise. So we have done the capillary electrophoresis. Here, not the HbA1c, either is fine. And it says HbA 94%, HbA2 5.4%. The cutoff of so in beta thalassemia trait, your HbA2 is elevated. HbA2 is 2 alpha and 2 delta. 2 alpha and 2 delta because it's a heterozygous mutation in the beta globin gene. So one beta globin gene is perfectly fine, working, and one beta globin gene is mutated, that is not working. So that is what is meant by beta thalassemia trait or carrier. If you have beta thalassemia major or disease, both beta globin genes will be mutated. In that scenario, you will have very high hemoglobin F, and you have all the clinical features within the first 2 years. So this child who is 3 years, HB9, has beta thalassemia trait because his HbA2 is 5.4. Now what? Now what's the management?
Reassure the patient.
Family screening.
Yes, family screening is important because someone, mother or father, or maybe both, may be having beta thalassemia trait.
And
Right. So yes, someone was.
Pediatrician.
Yes, but my task is to empower you to manage this in the general practice setting. So that is what we are trying to do. So you can, but this is something, again, beta thalassemia trait is something you can handle in the general practice if you are well knowledgeable, and there's no necessity to refer to the pediatrician as such. Right. So anyway, we know your hemoglobin is formed by 2 alpha and 2 beta globin chains. And as I have correctly previously shown, one of these will be mutated in beta thalassemia trait. Beta thalassemia trait, we know, is an asymptomatic condition. It's very, very common in this country. It is detected incidentally or by carrier screening because they will be perfectly normal. There are no symptoms, there are no signs. When you do a full blood count, maybe hemoglobin, many it will be 9, 10, but some people can have hemoglobin of about even 11, 12. Sometimes there may not be even anemia. So it's incidentally detected. So laboratory abnormalities, mild anemia, HB 8 to 11. Generally, it will not go below 7. It will not go below 7. And your MCV and MCHC will be low, and the HPLC will show high HbA2, more than 3.4%. How prevalent is this? Yes, it's highly prevalent. 2 to 3% of Sri Lankan population are having thalassemia trait. That is what our surveys have found. So that is 1 in 30 to 1 in 40, right? 1 in 30 to 1 in 40 will be thalassemia trait. So if you see 30 patients in your general practice per day, one person is likely to have thalassemia trait. That is so common, beta thalassemia trait. Many are undiagnosed. That was initially found most predominantly in the north central and northwestern provinces, Kurunagal and Anuradhapura. Still, it's the case. However, thalassemia trait is now seen everywhere. So with varying prevalences, even in Gampaha, Colombo, we diagnose very often thalassemia trait. So once we make the diagnosis, there's no specific treatment needed. So they will be a bit alarmed saying this sort of thalassemia, but what you need to make sure, sort of tell them is nothing to worry. This will not interfere with your day-to-day activities or life. So they can do everything, any sport you can participate, nothing. But whenever we check the hemoglobin will be slightly low, but that hemoglobin is sufficient to maintain the daily activities as well as any sort of exercise and sports. So there's no restriction in that. You don't have to restrict iron. Those things are not restricted. Exertion, exercise, no restrictions. If there are schools want you to sign a child with thalassemia trait, you can say no restriction of activities without any issue. There's no indication to give folic acid. I have seen several people giving folic acid. There's no indication. So just leave. We generally do not consider this as a disease. This is a part and parcel of our community. Only instance where you have to be cautious is the time where you find your partner for the marriage. When this child, so if it is a child, 2-year-old child, when this child is sort of finding the partner for the marriage, then the partner needs to be fully screened to exclude thalassemia. So in general practice, you may be seeing adolescents and adults who are thalassemia, right? Again, the advice you need to give, the genetic counseling is screen your partner before the marriage. But because if you marry another thalassemia trait, there's 25% risk of getting a child with thalassemia. So which is not a reasonable risk to take. So genetic counseling, yes, so 25% risk of having a thalassemia. So sometimes we encounter, now they are married and by somehow detected both are thalassemia trait. So then probably it's maybe too much for the general practice. But the options of 25% risk is something that we do not recommend them to take, because having a child with thalassemia is really, really disastrous. We have seen the suffering of the family. So one is legal adoption, but other options are available nowadays. You can go for prenatal diagnosis and along with in vitro fertilizations. So, but those advices probably not something that you will be giving in the general practice. So refer to maybe a specialist on that. Right. So that is thalassemia trait. So third case scenario, 3-year-old boy with viral illness. Again, same child, similar child, clinical examination unremarkable, same hemoglobin 9, MCB 57, MCH, ferritin 80. We have thought this is going to be thalassemia trait. We did the HPAC, which has come as perfectly normal. Now what?
Megaloblastic anemia.
Megaloblastic anemia will give rise to macrocytosis, high MCB.
Okay.
Did you say sideroblastic anemia?
Sideroblastic anemia, yes.
Yeah, sideroblastic anemia is a possibility, but sideroblastic anemia is a condition which generally gives rise to hepatosplenomegaly, and it's a rare condition. So it's not, because clinical examination is unremarkable. Any other guesses? This is common
Anemia of
scenario.
chronic disease. Anemia of chronic
Artery
disease.
infection can increase.
You repeat the hemoglobin after the infection settles. So everything is exactly the same.
Renal disease.
Everything, nothing.
Lead poisoning.
No history of lead poisoning. Lead levels are normal.
Chronic.
Anemia of chronic disease.
No chronic disease in the child. Very well child.
Hydrate with ferritin high because of infection.
Nope. Even after the infection settles, ferritin remains normal.
Alpha thalassemia?
Yes, I just heard the answer. Most likely explanation is alpha thalassemia trait, which is something you are not very familiar with, but ironically, it's a very common condition in this country. So it's quite common for us in the pediatrics to see children with microcytic anemia, blood picture. If you have done, say, hypochromic microcytic anemia, thaltrate or iron deficiency. Iron deficiency is excluded by doing a ferritin. Beta thalassemia trait is excluded by HPAC. Alpha thalassemia trait cannot be excluded by the HPAC. So it can well be alpha thalassemia trait. It can well be alpha thalassemia trait. Is it common in Sri Lanka? Yes. So alpha thalassemia trait is something that is good to know for the general practitioners to know that something like this is existence. So we know, in contrast to beta globin, alpha globin is a duplicated gene. That means in each chromosome you have 2 genes. You would have learned during your medical school days. So each cell, there are 4 alpha globin genes. So There are instances where all four are mutated, not in Sri Lanka. All four alpha globin genes are mutated, as you see in the lower, which is known as hemoglobin Bart's hydrops fetalis. I'm sure you will remember your undergraduate hematology lectures telling about hemoglobin Bart's hydrops fetalis. No alpha globin. So fetal demise today. So if you have 3 mutations of alpha globin genes, that is known as hemoglobin H disease. 1 or 2 mutations of the alpha globin gene is known as alpha thalassemia trait. In this country, we don't see hemoglobin Bart's hydrops fetalis because the mutations causing Bart's hydrops fetalis are not there. SBH disease is also very, very rare, but alpha thalassemia trait is extremely common in Sri Lanka. We will know why it is. So it's due to 1 or 2 alpha globin gene deletion. And again, same as beta thalassemia trait. Asymptomatic mild microcytic hypochromic anemia, normal iron studies. Only difference is the HbA1c is normal. The HbA2 will not be high. Only way to diagnose is by genetic testing, which we have the facilities at Ragama. Some centers in Colombo can do that. And it's quite common. And it's actually more prevalent than beta thalassemia trait. More prevalent than beta thalassemia trait. However, we don't see. So we see beta thalassemia major very often. I'm sure everyone had seen a beta thalassemia major. But it's very rare for someone in Sri Lanka to see alpha thalassemia major, which is Bart's hydrops fetalis. I don't think anyone has seen a fetus, sort of hydrops fetalis fetus due to Bart's hydrops fetalis. That is because the mutations that we have in Sri Lanka are such that they will remove only one alpha globin gene from one chromosome. So if you can see my cursor, I don't know whether you will see, the Sri Lankan mutations will remove only one alpha globin gene from one chromosome. So even in the homozygous state, the maximum would be 1 deleted from each chromosome. That means 2 out of 4 are functional. Whereas in countries where you have Bart's hydrops fetalis, the Thailand, the mutations they have will remove both alpha globin genes in single chromosome. So when they are in the homozygous state, they will not have a single normal alpha globin gene. I'm sure, I don't know whether I was clear, but it's something interesting. So the reason why we don't see severe alpha thalassemia or Bart's hydrops fetalis in this country is the mutations that we have are different. However, alpha thalassemia trait causing mutations are very, very prevalent. So it's grossly undiagnosed because there are no facilities to diagnose. And we have done studies and we have seen majority, it's even higher than the beta thalassemia trait. The take-home message on this is, so if the child has anemia, microcytic anemia, and the ferritin is normal, the common practice is to think the ferritin is probably wrong. We will give iron. So you give iron, HbA1c done, it's normal. But how much iron you give, the hemoglobin will not improve. So we have seen, you may probably refer to the pediatrician, which is the right thing for you to do. But there are so many pediatricians we have seen continuing iron for years and years without a proper response. So that is, you need to know there's something called alpha thalassemia trait existing in this country, which can cause microcytic anemia, similar to iron deficiency, but will not respond into iron treatment. Any questions on that?
Genetic testing is available, sir?
Yes, it's available in Ragama Thalassemia Center and it's available in certain private laboratories. GeneTech and Asiri Genetics Laboratory, they do common genetic mutations. If you do it in the private sector, cost is around 25,000. If you want to do it in the Ragama Thalassemia Center, which is done free of charge. But those referrals generally needs to come through a hematologist or a pediatrician.
Sir, if it is genetically we diagnose, anyhow there is no treatment now.
No, not at all. It's an academic exercise. You know the course of thalassemia, and here even the genetic counseling is not required. So assume you diagnose alpha thalassemia trait in a child, then we don't recommend thalassemia screening of the partner because the type of mutation that we have in Sri Lanka will generally not cause alpha thalassemia major. Whereas if you are in Thailand, they will do the genetic counseling and they will do genetic testing of the partner. So just an academic exercise diagnosing alpha thalassemia trait, but as practicing clinician, you need to know there is something like this, which is common. The prevalence is 8%. It's quite common. And you will encounter them as iron deficiency, microcytic anemia refractory to iron treatment. That is because it's not iron deficiency. Okay. Right.
Yes, sir.
Go on. We
Yeah,
can answer.
yes, the beta thalassemia trait with iron deficiency anemia combined patients, do we need to treat with iron? No?
Good question. Yes, definitely. Yes, definitely. Yes, you need to treat. So I'll come to the last slide. So we'll show the last slide, and then you will understand how to handle. Yeah, it's point taken. They need to be treated with for iron deficiency, but in those ones, you may not be able to see a hemoglobin rise of 1 gram because they are already having alpha thalassemia trait. So in those children, you will probably have to go above the ferritin and to treat with iron until the ferritin is normalized. Okay, the last scenario, 3-year-old boy with viral illness, clinical examination unremarkable. So full blood count, hemoglobin 8, MCV low, MCH low, MCHC. So very clear microcytic anemia. We have done a ferritin, it's low. And hemoglobin HbA1c, it's normal. So this is a quite straightforward case of iron deficiency anemia. And you start treatment with iron. After giving 3 months of iron treatment, you repeat the hemoglobin, it's still the same, more or less the same. So this is a child who has iron deficiency, but refractory to the iron treatment. So what are the causes for refractory iron deficiency, which can be very commonly seen in general practice? You give iron, the hemoglobin does not go up. But you know the ferritin was low. This child has iron deficiency, but the hemoglobin is not good. The causes can be poor compliance. The child may be not taking iron. Or then you will probably have to exclude the other causes of refractory iron deficiency anemia, which can be occult blood loss. Maybe there is a continuous GI bleed like celiac disease, cow's milk protein intolerance, sometimes the diverticular disease, Mecker's diverticular. So these children needs to be referred to pediatrician because the pediatrician should evaluate by doing occult blood and maybe endoscopies may be needed. So these children will be should be referred. There is another rare genetic entity known as iron refractory iron deficiency anemia, which I'm not going to talk because it's beyond the general practice. So if someone is diagnosed with iron deficiency and you treat with iron, does not show a response by hemoglobin, you may try another 1 month. So if it is not responding within 2 months, you have to refer to the pediatrician or a suitable person to evaluate further because it's iron refractory iron deficiency anemia. So what you can do in the general practice, if you have found an asymptomatic child with microcytic anemia, I would recommend doing both serum ferritin and hemoglobin HbA1c. Although the iron deficiency is the commonest cause, beta thalassemia trait is very, very common in Sri Lanka. And there's a national thalassemia screening program. In the national thalassemia screening program, what is recommended is to do a full blood count when the MCV is low, to go and proceed with HbA1c. So now you have encountered this child in your general practice who have fulfilled the criteria in the national screening program for screening for thalassemia. He has a HB low, MCV is low. So in these ones, we should not be missing beta thalassemia trait because it's a one-off diagnosis. You make the diagnosis and you do the proper counseling so that it will help to prevent thalassemia in this country. So everyone with microcytic anemia, I would recommend, if facilities are available, to do serum ferritin and hemoglobin HbA1c. If the ferritin is low, HbA1c is normal, iron deficiency anemia, you treat with oral iron. If ferritin is low, HPLC is high HbA2, that is combined iron deficiency anemia and beta thalassemia trait. So they need genetic counseling and oral iron treatment until the ferritin is normalized. If ferritin is normal, HPLC is so HbA2 high, it's beta thalassemia trait, no iron deficiency, no need of iron therapy, no need of anything else, but just genetic counseling as we described before. In rare instance where the ferritin is normal and HPLC is normal, likely to be alpha thalassemia trait. In the general practice settings, you will not be able to diagnose. You may suspect alpha thalassemia trait and you can sort of refer to a sort of a specialist for further management. Even with iron deficiency anemia with refractory to iron treatment, again, you need to refer to a specialist. So I think that's all I have to tell. So we have discussed about the microcytic anemia, which is the 90% of your general practice. Normocytic anemia, it can be hemolytic anemia, which needs to be referred. Macrocytic anemia, again, needs to be referred. Any questions?
So ferritin up to what level we have to do it? 80 or 60? The iron
15 is the cutoff. 15
Cutoff.
is the cutoff. Less than 15, iron deficiency. More than 15, normal.
and
1.5, 1.5.
iron deficiency plus beta thalassemia trait patient. Up to which ferritin level we have to give iron therapy, sir?
15. When
50.
it is go up 1.5.
1.5. Okay, sir.
Yeah, that's the normal. You make sure the ferritin becomes normal.
So what's happened? Beta thalassemia trait plus alpha thalassemia trait get married? Is
Nothing.
that nothing?
No problem. No problem. If only problem is beta thalassemia trait getting married to a beta thalassemia trait.
Yeah. Okay, sir. Thank you.
Okay, if there are any other questions, so I'll leave. Thank you
So,
for listening.
sir, we are
Thank you so much, Professor Sachit. That's a very informative and more towards GP practice. Thank you so much. I like to thank you on behalf of the college.
Thank you.